Hello there. So now let's move on to the next scenario here. Now we have a 49-year-old female presenting with right hypochondrial pain. An ultrasound shows a large gallstone. Her blood pressure is 120/85, respiratory rate is 18, heart rate is 90, temperature 37.6, WBC count is 15. Now, the most appropriate management in this case that is being asked here. So here we have to carry out laparoscopic cholecystectomy. As the patient is symptomatic, so reassurance is out of question. The two remaining options are laparoscopic cholecystectomy or emergency laparotomy. Now, laparoscopic cholecystectomy is a preferred option here as there are no signs of gallbladder perforation. So there are no signs of gallbladder perforation. That's why we can go ahead with laparoscopic cholecystectomy. Laparotomy or emergency laparotomy has a higher risk as it is much more invasive as compared to cholecystectomy. So if the patient is asymptomatic and is a case of cholelithiasis, we have to reassure the patient. And if the patient is symptomatic with cholecystitis but stable, then we can carry out laparoscopic cholecystectomy. But if the patient is unstable, then we can carry out emergency cholecystectomy. And in the case of choledocholithiasis, no matter what, whether the patient is symptomatic or not, we have to treat the patient. That is, we have to carry out cholangiopancreatography. We have to carry out ERCP in that case, in case of choledocholithiasis. Now we will study about acute cholecystitis here. Acute cholecystitis usually follows stone impaction in the neck of the gallbladder, which may cause continuous epigastric or right upper quadrant pain, which is referred to the right shoulder. And there may be symptoms like fever, vomiting, local peritonism. Occasionally, a right upper quadrant mass is also palpable, which is distended gallbladder or an inflammatory mass surrounding the inflamed gallbladder. So this is about acute cholecystitis. It usually follows a stone impaction in the neck of the gallbladder and which may cause continuous epigastric pain or right upper quadrant pain, which is referred to the right shoulder. And patient is having fever, vomiting, local peritonism. Occasionally we may find a right upper quadrant mass which is palpable, which is either a distended gallbladder or an inflammatory mass surrounding the inflamed gallbladder. The main difference from biliary colic is the inflammatory component here. In biliary colic, there is no inflammatory component. In acute cholecystitis, we have an inflammatory component. So here we will have features like fever, local peritonism, elevated white cell count. So these will be found, these features, because of the inflammatory component in acute cholecystitis, which sets it different from biliary colic, which is the main difference from biliary colic. We will see symptoms like fever, elevated white cell count, and elevated blood cell count, white cell count, and local peritonism, etc. If the stone moves to the common bile duct, then we can see obstructive jaundice and cholangitis. Murphy's sign is positive when we lay two fingers over the right upper quadrant and we ask the patient to breathe in, which causes the pain and arrest of inspiration as an inflamed gallbladder impinges on the fingers. So Murphy's sign is positive when we lay two fingers over the right upper quadrant of the patient, right upper quadrant of the abdomen, and we ask the patient to breathe in. So when the patient breathes in, it causes pain and it causes arrest of inspiration because an inflamed gallbladder impinges against the fingers. It is only positive if the same test in the lower, in the left upper quadrant of the abdomen is not causing any pain. So tests would be both WBC count, white cell count, and CRP would be elevated here because of the inflammatory component, and ultrasound will show a thick walled shrunken gallbladder. In acute cholecystitis, we will see a thick walled and shrunken gallbladder in ultrasound. Management is we have to keep the patient nil by mouth, analgesia, then IV fluids and antibiotics. Once the symptoms settle, we have to do a laparoscopic cholecystectomy. Laparoscopic cholecystectomy is a treatment of choice for all the patients who are fit for general anesthesia. Open surgery is required if there is gallbladder perforation. So this is about acute cholecystitis, which usually follows stone impaction in the neck of the gallbladder, which may cause continuous epigastric or right upper quadrant pain, which is referred to the right shoulder. There may be symptoms like fever, vomiting, local peritonealism. Occasionally, we may find a right upper quadrant mass which is palpable, which is either an inflamed gallbladder or an inflammatory mass surrounding the inflamed gallbladder. The main difference from biliary colic is that here inflammatory component is present, fever will be there, white cell count will be raised, local peritonealism is there. If this stone moves towards the common bile duct, it may cause obstructive jaundice and cholangitis. Murphy's sign here will be positive. Now, how to check for Murphy's sign? Murphy's sign is positive when we lay our two fingers over the right upper quadrant of abdomen and we ask the patient to breathe in. During this, when the patient breathes in, it will cause pain to the patient, and it will also cause arrest of the inspiration because the inflamed gallbladder will impinge against our fingers. But this test is only positive if the same test is negative in the left upper quadrant of abdomen. Now the investigations here will be CRP and white cell count both would be raised, both are elevated. In ultrasound, in acute cholecystitis, we will see a thick walled and shrunken gallbladder. Management is done by nil by mouth. We have to keep the patient. Analgesia is done. Then IV fluids are given. Antibiotics are given. Once the symptoms settle, then we have to carry out laparoscopic cholecystectomy. Laparoscopic cholecystectomy is a treatment of choice for all the patients who are fit for general anesthesia. Open surgery is required if there is gallbladder perforation. So this is about acute cholecystitis. Now let's move ahead. Let's once quickly go through the chart here. So acute cholecystitis presentation, we have acute severe right upper quadrant pain or epigastric pain radiating to the right shoulder. We have nausea, vomiting and fever. We have Murphy's sign, which is pain on deep inspiration as the finger touches the inflamed gallbladder. Most common cause is blockage of the cystic duct by gallstone or due to impaction of gallstone in the neck of the gallbladder, or blockage of the cystic duct by a gallstone causes acute cholecystitis. Investigation, ultrasound abdomen, treatment laparoscopic cholecystectomy. Here we can see in this picture gallstone causing impaction in the neck of the gallbladder. Gallstone in an asymptomatic patient, we have to offer reassurance. Now here we can see gallstone in cystic duct and gallstones in gallbladder, which may cause inflammation. So this is acute cholecystitis. But if this stone further moves towards common bile duct, it can cause obstructive jaundice or cholangitis. So these are the things which we have to remember. Presentation, that is right upper quadrant pain or epigastric pain radiating to the right shoulder, fever, vomiting, nausea. Murphy's sign is positive, which is pain on deep inspiration as the finger touches the inflamed gallbladder. Most common cause here is blockage of cystic duct by the gallstone. Investigation ultrasound abdomen. Treatment laparoscopic cholecystectomy. We have to offer reassurance in a patient who is asymptomatic with gallstones. Now, this is about the chart. Let's move to the next scenario. So, you are a junior doctor in a busy emergency department. A 65-year-old male presents with significant hematemesis. Following his resuscitation, you thoroughly examine him. You find he has a distended abdomen, hepatomegaly, and ascites. He is also remarkably jaundiced with spider nevi on his chest. He also has evidence of gynecomastia, and he has a significant medical history of chronic heavy alcohol consumption, having drunk on average 2 1 liter bottles of whiskey weekly for the past 25 years. Hemoglobin is 120, MCV is raised 110, GGT is 202 raised, ALT is 70, AST is 150, and alkaline phosphatase is 160. So, what is the single most diagnosis here? Single most cause diagnosis. So, here we are seeing a case of alcoholic liver disease, that is ALD. 70% have raised AST ALT ratio, GGT is also raised, and cirrhosis of liver leads to portal hypertension, which leads to esophageal varices causing spider nevi, upper GI bleed, and alcoholic liver disease, and end stage liver disease requires liver transplant, and there is 6 month period of complete abstinence. These are the few highlighted things here to remember. So this question reveals many signs of a classic presentation of alcoholic liver disease. The main indicator that would point towards alcoholic liver disease diagnosis would be just from the history of alcohol excess alone. However, despite the history and examination, for a definitive diagnosis, the first line investigation would be serum AST to ALT ratio. So we have to see here AST to ALT ratio and GGT levels. These are the two main investigations which we have to see to make a confirmed diagnosis for a definitive diagnosis. AST to ALT ratio and GGT level, apart from the history taking of alcohol intake. Now, in alcoholic liver disease patients, AST is almost always raised and it is higher compared to ALT. 70% of alcoholic liver disease patients have this raised AST to ALT ratio. The reversal of AST ALT ratio could suggest viral hepatitis or non-alcoholic fatty liver disease. If we see reversal of this ratio, AST to ALT ratio, if we see reversal of this ratio, then it could suggest viral hepatitis or non-alcoholic fatty liver disease. GGT would also be raised in alcoholic liver disease. Now, the first line management for alcoholic liver disease is abstinence from alcohol. Alcohol abstinence with the help of alcohol withdrawal management. The patient in the question presented with severe hematemesis. From his diagnosis, it would suggest his upper GI bleed was from esophageal varices, which are a complication of portal hypertension secondary to cirrhosis of the liver. So because of alcoholic liver disease, liver cirrhosis happened, which further caused portal hypertension. Liver cirrhosis caused portal hypertension, and as a complication of portal hypertension, esophageal varices developed, which led to upper GI bleed. So that was the reason of hematemesis. Liver cirrhosis, portal hypertension, esophageal varices, upper GI bleed, hematemesis. This indicates end stage alcoholic liver disease. The patient should be considered for a liver transplant if he has at least a 6-month period of confirmed abstinence. So these are the things which we have to remember in case of an alcoholic liver disease patient. Let me see if we have a chart on this. Okay, so this case is a classic presentation of alcoholic liver disease. The main indicator here is the history of excess alcohol intake. But despite history and examination, for a confirmed diagnosis, we need to see two investigations. First is AST to ALT ratio, second is GGT levels. The first line investigation would be serum AST ALT ratio and GGT. In alcoholic liver disease, AST is almost always raised and higher compared to ALT. 70% of alcoholic liver disease patients have this raised AST ALT ratio. The reversal of this AST-ALT ratio could suggest viral hepatitis or non-alcoholic fatty liver disease. GDT levels are also raised in alcoholic liver disease. The first line management for alcoholic liver disease is abstinence from alcohol with the help of alcohol withdrawal management. Alcohol withdrawal management. Alcohol abstinence is the first line management with the help of alcohol withdrawal management. The patient here presented with severe hematemesis. So what could have happened? So because of alcoholic liver disease, it caused liver cirrhosis, which caused portal hypertension, which caused esophageal varices, which led to hematemesis. So this indicates end stage liver disease because it is liver cirrhosis. So it indicates end stage alcoholic liver disease. The patient should be considered for a liver transplant if there is a confirmed period of 6 months of alcohol abstinence. There should be at least a 6-month period of confirmed abstinence from alcohol. Then this patient should be considered for a liver transplant. Now let's move further. Now we have a 43-year-old lady who had endoscopic retrograde cholangiopancreatography. So ERCP was done on this lady, that is endoscopic retrograde cholangiopancreatography. And it was done for gallstone disease. 24 hours after the procedure, the patient returns to the emergency department with severe right upper quadrant pain. So ERCP, we have to remember it is an endoscopic procedure because obviously ERCP is endoscopic retrograde cholangiopancreatography. So here the patient returned to emergency department with severe right upper quadrant pain. On examination, she appears generally unwell with a pyrexia of 38.9 degrees Celsius. She looks yellow. She is extremely tender in the right upper side of her abdomen. What is the diagnosis here? Single most likely diagnosis here. So we have different options here. We'll rule out. The correct answer here would be ascending cholangitis. Now this is a classical presentation with Charcot striae of fever, right upper quadrant pain and jaundice. Here we see fever is there, right upper quadrant pain is there, and jaundice is there. So Charcot striae is there of ascending cholangitis. Now abdominal sepsis is one of the 3 most common types of sepsis. Particularly as this lady recently had a procedure, the time of presentation is most suspicious of an infective pathology. So why this is not acute pancreatitis? Because The patient classically presents with profuse vomiting and epigastric pain, which classically radiates to back. In case of acute pancreatitis, the patient presents with profuse vomiting and epigastric pain, classically radiating to the back, which is not the case here. Now, why it is not acute cholecystitis? Although it is a good differential given the presentation, but it is not the single best answer given the history of jaundice here. Jaundice is not typically present in cholecystitis unless, as we studied, unless the stone moves to the common bile duct and causes obstructive jaundice. So in acute cholecystitis, jaundice is not typically present. Now, why it is not cancer of the head of the pancreas? Because there is nothing in the question to suggest a malignant pathology such as weight loss. Most important, weight loss. It's not there. Furthermore, the classical presentation of cancer of the head of the pancreas is painless jaundice. In cancer of the head of the pancreas, we have jaundice, but it is painless. We don't have any pain. So there classically we have painless jaundice in cancer of the head of the pancreas, which is not the case here. Now, why it is not upper GI perforation? Upper GI perforation is incorrect, as in upper GI perforation, the patient usually presents with generalized abdominal tenderness, with guarding, and the patient will typically be much more unwell. This is a good differential to keep in mind, as the patient did just have recent endoscopy. So, however, if a perforation had occurred, the patient would have become unwell immediately at the time of the event, not 24 hours later. So here we have to see perforation usually presents immediately. It doesn't take too much time. Here the patient presented after 24 hours, and the patient is much more unwell in case of perforation. However, it is a good differential. And in that case, we won't have right upper quadrant pain. In case of perforation, we'll have generalized abdominal tenderness along with guarding. Generalized abdominal tenderness along with guarding. So this is a case of ascending cholangitis. And we have Charcot's triad here, that is fever, right upper quadrant pain, and jaundice. Now, abdominal sepsis is one of the three most common types of sepsis, particularly because this patient recently had a procedure, and the time of presentation is more suspicious of an infective pathology. Acute pancreatitis also develops within 6 to 12 hours. It doesn't take too much time. And also, there the patient presents with vomiting, epigastric pain, which is radiating to the back. Now let's move ahead. The key points to remember for this question is ascending cholangitis presents with a triad of fever, right upper quadrant pain, and jaundice. That is Charcot's triad. Charcot's triad is present in ascending cholangitis. That is the key point to remember here. So let's study about ascending cholangitis a little. Ascending cholangitis is where there is evidence of obstruction with superimposed infection within the biliary tree. It is usually a complication of stones in the duct. We have to look for Charcot's triad, that is fever, right upper quadrant pain, and jaundice. Only about 10 to 20% of the patients present with additional features like Reynolds pentad. In Reynolds pentad, along with the Charcot's triad, that is fever, right upper quadrant pain, and jaundice, we will also have hypotension and confusion. So, Charcot's triad plus hypotension and confusion is equal to Reynolds pentad. Now, blood picture. Blood picture in ascending cholangitis, we will have inflammatory markers and WBC would be raised like any infection. White cell count would be raised and inflammatory markers would be raised. LFTs would be deranged here, showing an obstructive pattern. So ALP would be much more raised than ALT, and conjugated bilirubin will be very high. So obstructive pattern, in case of obstructive pattern, conjugated bilirubin is high and ALP is much more raised than ALT. This we have to remember. That in case of obstructive picture of jaundice, ALP is much more raised than ALT and conjugated bilirubin is very high. Investigations here in ascending cholangitis would be first, ultrasound abdomen may show gallstones and dilated common bile duct. Then CT scan will show dilated biliary system with associated inflammation. Now MRCP may show gallstone or stricture in the biliary tract. MRCP may show gallstone or stricture in the biliary tract. And ERCP, in addition to the investigating, it can also be used for intervention. So unlike many conditions, it is difficult to put an investigation as the most appropriate investigation for ascending cholangitis. But there are certain clues onto what to put for the exam. Like if the question asks for best first line investigation for ascending cholangitis, it would be ultrasound abdomen, which is the best first line investigation. Ultrasound abdomen. There we'll see gallstones and dilated common bile duct. Next investigation, if ultrasound is inconclusive or we have a negative ultrasound, then we can perform MRCP or CT scan. Both are considered very useful. In MRCP, we will see gallstones or stricture in the biliary tract. In CT scan, we'll see dilated biliary system with associated inflammation. Now, ERCP can be considered as a gold standard for investigation and for interventions, but it is not one of the initial tests because it is an invasive procedure. Endoscopic retrograde cholangiopancreatography. It involves inserting an endoscope to the duodenum and cannulation of the ampulla. It can determine the cause of the ascending cholangitis and can also extract stones or place stents. Since it is invasive, it carries the risk of complications such as acute pancreatitis. As a result, other imaging modalities should ideally take place first. Management. Management would be intravenous antibiotics. If it does not respond, then it may require percutaneous, endoscopic, or operative interventions. In cholangitis, we will have both obstruction as well as infection. Obstruction along with infection within the biliary tree. That will indicate towards ascending cholangitis. And it is usually a complication of gallstones in the common bile duct, in the duct. It is usually a complication of stones in the duct, and here in ascending cholangitis, we have to look for Charcot striate, that is fever, right upper quadrant pain, and jaundice. Only 10 to 20% of the patient presents with the Reynolds Pentard. Reynolds Pentard is Charcot striate plus hypotension and confusion. Now the blood picture here, because of inflammation, here both white cell count and inflammatory markers would be raised because of inflammation, just like any other infection. Because we have here both obstruction as well as infection. Second thing here, LFT would be deranged and we will see an obstructive pattern, that is ALP would be raised much more than ALT. Alkaline phosphatase would be raised much more than alanine transaminase. And conjugated bilirubin will be very high. ALP raised more than ALT and conjugated bilirubin very high, obstructive pattern. So we have seen both infection as well as obstruction within the biliary tree. Now investigations which we'll perform are first line investigation for ascending cholangitis is ultrasound abdomen, where we'll see gallstones and dilated common bile duct. It may show gallstones and dilated common bile duct. Further investigations which we can perform are CT scan and MRCP. In CT scan, it will show dilated biliary system with associated inflammation. MRCP may show gallstones or stricture in the biliary tract. May show gallstones or stricture in the biliary tract. ERCP here, it can be used for investigation as well as for intervention. So best first line investigation, ultrasound abdomen remains the best. Next investigation, if ultrasound is inconclusive or negative, then MRCP or CT scan. Both are useful. ERCP is considered as a gold standard for investigation and interventions, but it is not one of the initial tests because it is an invasive procedure. Here we insert an endoscope to the duodenum and we carry out cannulation of the ampulla. It can determine the cause of the ascending cholangitis, and we can also extract stones or place stents inside. Since it is an invasive procedure, so there is a risk of complications such as acute pancreatitis, and so other imaging modalities should ideally take place first before this invasive procedure. Management of ascending cholangitis is done by intravenous antibiotics, and if it is not responding, patient is not responding to this, then it may require percutaneous, endoscopic, or operative interventions. Now let's move further. Now we have a 33-year-old man attending GP surgery with a history of 7 days of epigastric pain. He describes it as burning sensation. He was treated with H. pylori eradication regimen 6 weeks ago following an endoscopy, which shows a duodenal ulcer with a positive test for H. pylori. He is a non-smoker. What is the single most appropriate test to ensure successful eradication of H. pylori? So NICE recommends carbon 13 urea breath test for retesting of Helicobacter pylori. Urea breath test should be arranged 6 to 8 weeks after starting initial eradication therapy in the patients who have a proven duodenal ulcer who have refractory or recurrent symptoms. If the urea breath test is not available, then stool antigen test would be appropriate. If urea breath test is positive, another attempt to eradicate Helicobacter pylori would be appropriate. It is also important to remember these 2 points. Proton pump inhibitors must not be used 14 days prior to testing. There must be a 28 days break after treatment with an antibiotic prior to the testing. Endoscopy is only required if H. pylori is completely eradicated, as shown by urea breath test, to further investigate the cause of dyspepsia. So, according to NICE guidelines, it is recommended that carbon 13 urea breath test is carried out for retesting of Helicobacter pylori. Urea breath test should be arranged 6 to 8 weeks after starting initial eradication therapy in patients who have a proven duodenal ulcer who have refractory or recurrent symptoms. So this urea breath test is arranged 6 to 8 weeks after starting the initial eradication therapy in patients with duodenal ulcer who have refractory or recurrent symptoms. If urea breath test is not available, then we can carry out stool antigen test. It would be appropriate. Now, if the urea breath test is positive, then another attempt to eradicate Helicobacter pylori is appropriate. And it is important to remember that proton pump inhibitors must not be used at least 2 weeks or 14 days prior to testing. And second thing is there must be a 28 days break after the treatment with an antibiotic prior to testing. So there must be a 28 days break after treatment with an antibiotic before testing. Endoscopy is only required if H. pylori is completely eradicated as shown by urea breath test, but we have to further investigate the cause of dyspepsia. Then we can carry out endoscopy. Now let's move ahead. A 26-year-old man has a history of passing loose stools for the past 2 months. He says his stools contain a small amount of blood and mucus and is associated with abdominal pain. He has around 4 to 5 bowel movements in a day. His blood results show ANCA positive and ASCA negative. Colonoscopy was organized and performed, after which he was started on a treatment. What is the single most appropriate treatment for his condition? So, the clinical features and treatment after colonoscopy suggest diagnosis of inflammatory bowel disease. ANCA positive and ASCA negative suggest a high probability of diagnosis being ulcerative colitis. For ulcerative colitis, initial treatment of mild to moderate symptoms is mesalazine. So here our answer would be mesalazine. Let's study a little about ulcerative colitis management. In ulcerative colitis management, we have to see two things. First, inducing remission. Second, maintaining remission. Inducing remission, first line, topical aminosalicylates, that is rectal mesalazine. Rectal aminosalicylates are better than rectal steroids and also better than oral aminosalicylates alone. If the patient is not responding, then we will add oral mesalazine. If still not responding, then we will add oral prednisolone. If there is severe colitis, then we have to treat the patient in hospital with IV steroids as the first line. Now, how we will know that it is a case of severe colitis? The patient is having severe colitis if following symptoms are present. First, 6 or more bowel movements per day, plus at least one of the following. First, fever more than 37.8 degrees Celsius. Fever more than 37.8 degrees Celsius. Then, second, tachycardiac and anemic. Fourth, ESR more than 30. So, if the patient is having 6 or more than 6 bowel movements in a day, plus at least one of the following, that is fever more than 37.8, ESR more than 30, tachycardiac or anemic, then we will consider this case as a case of severe colitis. And in case of severe colitis, we have to treat the patient in hospital and we have to give IV steroids as the first line. We will not start with first line as topical aminosalicylates such as rectal mesalazine. We will not be using oral mesalazine or oral prednisolone. Now, maintaining the remission. For maintaining remission, we use oral aminosalicylates such as mesalazine. If remission is not well maintained, then we can consider oral azathioprine or mercaptopurine. So this is about ulcerative colitis management. So treatment is based on severity. We have to know mild to moderate symptoms. First line, treat with topical aminosalicylates, mesalazine so as to induce remission. Mild to moderate symptoms usually involve a bowel movement of less than 6 times a day. 6 is a threshold here. So again, in ulcerative colitis management, we have to see two things. First, inducing remission. Second, maintaining remission. For inducing remission, first line is topical aminosalicylates, that is rectal rectal mesalazine. These are better than rectal steroids and also better than oral mesalazine. If the patient is not responding to topical aminosalicylates such as that is rectal mesalazine, then we will add oral mesalazine. If the patient is still not responding, then we will add oral prednisolone. Now, the story is different if it's the case of severe colitis. If the patient is having severe colitis, that is, if the patient is having 6 or more than 6 bowel movements in a day, plus at least one of the following, that is fever or temperature of more than 37.8 degrees Celsius, ESR more than 30, tachycardiac or anemic. If these features are present, then it is a case of severe colitis, and in that case, we will give IV steroids. In that case, we will treat the patient in the hospital and we will start as first line treatment would be IV steroids in that case. Now, second thing is maintaining remission. Maintaining remission is done by oral aminosalicylates, that is mesalazine. If remission is not well maintained, then we can consider oral azathioprine or mercaptopurine. So that is about ulcerative colitis management. uh, and about the use of mesalazine in that. Let's move ahead. Now we have a 69-year-old smoker who has had increasing dysphagia when eating solid food, which has been ongoing for the past 3 months. He has noticed a drop of 8 kg in weight for the past few months. He now finds drinking fluids difficult as well. What is a single investigation which is most likely to lead to a diagnosis? So, this is a case of esophageal cancer. The likely cause is esophageal cancer where a malignant stricture or mass has resulted in difficulty in swallowing. Now, if there is dysphagia, initially to solids, but it progresses to also involve liquids, then it is most likely a mechanical obstruction, not a motility obstruction. So, a mechanical obstruction, esophageal cancer is an example of mechanical obstruction, and in that case, an endoscopic biopsy is a definitive investigation. Now, esophageal cancer, stricture, and esophageal ring, these are the examples of mechanical obstruction. In motility problems or motility obstruction, we will have achalasia, scleroderma. But here, as we can see, this dysphagia is progressive. It is a case of esophageal cancer. Dysphagia was initially to solids but is further progressing to involve liquids. So it's a mechanical obstruction. It is not spontaneously for both solids and liquids at the same time. Now, in esophageal cancer, endoscopy and biopsy. Endoscopic biopsy is the definitive investigation. So this is about it. So answer would be endoscopy and biopsy here. Let's move ahead. Here we can see esophageal and gastric cancer. It is important to remember when to refer for an urgent esophagogastroduodenoscopy, OGD. Esophagogastroduodenoscopy, that is a type of endoscopy. Urgent upper GI endoscopy if the patient is having dysphagia, or if the patient is 55 years of age and over with weight loss and having any of the symptoms like dyspepsia, upper abdominal pain, or reflux. So when we have to refer the patient for an urgent endoscopy, urgent upper GI endoscopy, or urgent esophagogastroduodenoscopy, either the patient is having dysphagia or the patient is 55 years of age with weight loss and any of the following, that is dyspepsia, upper abdominal pain, or reflux, then we can refer this patient for urgent upper GI endoscopy or urgent esophagogastroduodenoscopy. Now let's move ahead. Now we have a 23-year-old woman who has abdominal bloating, weight loss, and intermittent diarrhea. Abdominal bloating, weight loss, and intermittent diarrhea. She describes her stools as frothy and difficult to flush down the toilet. Her blood tests show hemoglobin 105, white cell count 7.1, platelet count 350, ferritin level 11, B12 level 225, folate 1.9. Now, what is the single most appropriate test to next perform here? Now, this is a case of celiac disease, and in celiac disease, anemia, low ferritin levels, folate levels are characteristic of celiac disease. A tissue transglutaminase antibodies IgA, TTG IgA should be performed next. If the tissue transglutaminase antibody test is positive, then a duodenal biopsy should be done so as to confirm the diagnosis. So we already have studied about celiac disease earlier. Celiac disease is an autoimmune condition which is caused by sensitivity to the protein gluten, and repeated exposure to gluten, rye, wheat, barley leads to villus atrophy, which results in malabsorption. So it results in malabsorption. It is an autoimmune condition caused by sensitivity to the protein gluten, and ultimately, due to repeated exposure to these allergens, there is villus atrophy, which is leading to malabsorption. Clinical features would be chronic or intermittent diarrhea, stinking stools, steatorrhea, persistent unexplained GI symptoms such as bloating, nausea, vomiting, fatigue, unexpected weight loss, unexplained iron, vitamin B12, and folate deficiency in children, tapering growth. Complications can be osteoporosis or T cell lymphoma. Investigations specific antibodies, autoantibodies such as tissue transglutaminase antibodies, IgA, which are the first choice according to NICE guidelines. Second, IgA endomysial antibodies, anti-endomysial antibodies, IgA. Second investigations are jejunal or duodenal biopsy. Biopsy is still needed so as to confirm the diagnosis, even if the antibody tests are positive for celiac disease. Biopsy will show villus atrophy, crypt hyperplasia, and increase in intraepithelial lymphocytes. The serology tests or biopsies for celiac disease are not accurate if a gluten-free diet is eaten during the diagnostic process. Therefore, patients should not start a gluten-free diet until celiac disease is confirmed, which is often distressing to the patient as they would continue to be symptomatic. If the patient are already taking a gluten-free diet, we have to advise them to reintroduce gluten for at least 6 weeks prior to testing. Management is gluten-free diet. So clinical features are of celiac disease are chronic or intermittent diarrhea, stinking stools, steatorrhea, GI symptoms like bloating, nausea, vomiting, fatigue, unexpected weight loss, malabsorption is there, so unexpected weight loss, fatigue, and iron deficiency, vitamin B12 deficiency, and folate deficiency, and tapering growth in children. Complication can be osteoporosis, T cell lymphoma of small intestine. Investigations: tissue transglutaminase IgA antibodies, which are the first choice. Tissue transglutaminase TTG IgA antibodies. First choice according to NICE guidelines. Second, anti-endomysial Ig antibodies. Anti-endomysial antibodies, which are Ig antibodies. Second is duodenal or jejunal biopsy, which is needed to confirm the diagnosis, even if the antibody tests are positive, which will show villus atrophy, crypt hyperplasia, increase in intraepithelial lymphocytes. Now we have to make sure the patient is not on gluten-free diet, and if they are, we have to reintroduce gluten for at least 6 weeks prior to testing. So we have to advise them not to start gluten-free diet until celiac disease is confirmed by this biopsy or serological tests, because they would not be accurate if the patient takes gluten-free diet. So it can be distressing to the patient as they'll be symptomatic. Management is gluten-free diet. In the chart, we can see malabsorption syndrome due to inflammatory response to gluten present in wheat rye barley. It is an autoimmune condition, and it is basically caused by sensitivity to the protein gluten. So malabsorption is caused due to repeated exposure due to villus atrophy. Malabsorption syndrome due to inflammatory response to gluten present in wheat, rye, and barley. Another is one other presentation is skin manifestation, which is dermatitis herpetiformis, which is commonly seen on extensor aspects. Here we see investigation TTG, IgA, anti-endomysial antibody IgA, and biopsy, duodenal or jejunal biopsy. Gluten-free diet in the management. Okay, so this is about celiac disease. Let's now move ahead. Now we have a 36-year-old lady who has diarrhea for the last 2 months. She has lost 8 kgs in that time period. A colonoscopy was performed showing fistulas. Perianal fistulas are also noticed. What is the single most likely diagnosis here? So here in the complication we see fistulas. We have to understand that when we see Crohn's disease versus ulcerative colitis, see, we have to understand that in Crohn's disease, complication would be fistulas, stricture, colorectal cancer, osteoporosis. But here, in case of ulcerative colitis, complication would be colorectal cancer, toxic megacolon, and osteoporosis. We will not have fistulas and stricture in ulcerative colitis. So the diagnosis of Crohn's disease is quite clear here. Fistulas helps in differentiating between ulcerative colitis and Crohn's. Since fistulas are present, it can only be Crohn's disease. Let's go through the chart of Crohn's and ulcerative colitis. In Crohn's disease, we will have skip lesions and it can occur anywhere in the GIT. Whereas ulcerative colitis, we will have continuous lesions and it can only affect the colon. Crohn's disease is usually non-bloody diarrhea. In Crohn's disease, we will have non-bloody diarrhea. In ulcerative colitis, bloody diarrhea. In histology, we will have transmural ulcers and granuloma. In Crohn's disease, we will have transmural ulcers and granulomas. In ulcerative colitis, there will not be ulcers and there will not be granulomas. Here we will have crypt abscesses. Complications in Crohn's disease can be fistula, stricture, colorectal cancer, and osteoporosis. Here we can have colorectal cancer, osteoporosis, and toxic megacolon, which is a complication of ulcerative colitis. On endoscopy in Crohn's disease, we will see cobblestone appearance, cobblestone mucosa. Uh, Here in ulcerative colitis, on barium enema, we will see loss of hostrations or loss of hostral markings and drain pipe appearance. Treatment uh, in Crohn's disease would be glucocorticoid, azathioprine, mercaptopurine, infliximab, adalimumab. Here, treatment is in ulcerative colitis is mesalazine, corticosteroids, and cyclosporin. So, in Crohn's disease, treatment is glucocorticoids, azathioprine or mercaptopurine, infliximab, adalimumab. Glucocorticoids, azathioprine, mercaptopurine, infliximab, and adalimumab. Whereas in ulcerative colitis, the treatment will be mesalazine, corticosteroids. Here we will have corticosteroids, mesalazine, corticosteroids, and cyclosporin. Now, most commonly affected place in Crohn's disease, it can affect any part of the GIT actually, but the most commonly involved part is ileum. Whereas in ulcerative colitis, it affects mainly colon, and the most commonly affected part is rectum in ulcerative colitis. Location of the disease: mouth to anus, Crohn's disease, ulcerative colitis, colon, starting from rectum. It proceeds proximally. Colon starting from the rectum. Crohn's disease, we will have typically non-bloody type of diarrhea. Of course, bloody diarrhea can also occur, but in ulcerative colitis, we will have typically bloody diarrhea. Toxic megacolon is a complication of ulcerative colitis, rarely Crohn's disease. In this, we will have lead pipe appearance in barium enema, thumb printing, lead pipe appearance, all of these things. Here we can see in Crohn's disease, important points are diarrhea will be there, fever is there, we have diarrhea, non-bloody diarrhea, fever, tenderness at the right lower abdomen, tenderness at the right lower abdomen, ileitis due to ileitis, and mass at the right lower abdomen due to abscess. Fecal calprotectin helps in differentiating inflammatory bowel disease from irritable bowel syndrome. These are both two different types of inflammatory bowel diseases, Crohn's disease and ulcerative colitis. Fecal calprotectin helps in differentiating inflammatory bowel disease from irritable bowel syndrome. Colonoscopy is the best diagnostic test for Crohn's disease. Colonoscopy or endoscopy of colon. CT scan if the patient develops an abscess. So, fecal calprotectin, it is used to differentiate between inflammatory bowel disease and irritable bowel syndrome. When to use in cases where we are not quite sure if it is inflammatory bowel disease or irritable bowel syndrome. By doing the fecal calprotectin, we potentially reduce the amount of colonoscopies performed for investigating inflammatory bowel disease. So we reduce the amount of colonoscopies which are performed for investigating inflammatory bowel disease. Normal result, likely non-inflammatory, likely like irritable bowel syndrome. Abnormal result, possibly inflammatory bowel disease and should proceed for a colonoscopy. Do not do fecal calprotectin if there is new onset of rectal bleeding, if there is bloody diarrhea, or if the patient is over 50 years of age with a new change of bowel habits. The fear is that normal result could, could falsely reassure the clinician or patient and that they can miss something sinister. So fecal calprotectin, we have to remember it is used to differentiate between inflammatory bowel disease and irritable bowel syndrome, where we are not quite sure. And what is the significance? It helps in potentially reducing the amount of colonoscopies performed for investigating inflammatory bowel disease. So in fecal calprotectin, what is the normal result? Normal result is that there is no inflammation. Fecal calprotectin, normal result is likely it is non-inflammatory, so we will have irritable bowel syndrome, no inflammation. Abnormal result can be we will have possible inflammation, inflammatory bowel disease, and in that case, if we have inflammatory bowel disease, we should proceed for endoscopy or we should proceed further for colonoscopy. We do not do fecal calprotectin if there is a new onset rectal bleeding, or if there is bloody diarrhea, or the patient is 50 years or more of age with a new change of bowel habits, because in that case we can have false results, and we can miss something very important. Now, let's take a break for a while and I'll be back. Okay, now let's move further. Now we have here an 83-year-old woman who is a resident in a nursing home and is admitted to a hospital with a 4-day history of diarrhea. She has had no weight loss or change in appetite. She has been on analgesics for 3 weeks to manage her back pain. She is in obvious discomfort. Rectal examination reveals fecal impaction with hard stools. What is the single most appropriate immediate management in this case? So now they are asking not just the single most appropriate management, they are asking the single most appropriate immediate management. So here the answer would be phosphate enemas. Now this is an example of overflow diarrhea. Medications such as opioid pain relievers reduce intestinal movement and they may cause fecal matter to become too large, hard, and dry, making it difficult to expel. Subsequently, feces may become so hard that they cannot be expelled, and fecal fluid will flow around the block. Phosphate enemas contain sodium acid phosphate and sodium phosphate. The osmotic activity of sodium acid phosphate increases the water content of the stool so that rectal distension follows, and it is thought that this induces defecation by stimulating the rectal motility. It has a very quick onset of action, which makes enemas useful for when a rapid evacuation of a stony dull fecal impaction is required. Phosphate enema is a clear answer here as the question is addressing the immediate management. It is important to remember the relation between elderly bedridden individuals and fecal impaction. Fecal impaction is a fairly common complication of a long-term constipation in the elderly and bedridden patients, which is occurring in about 30% of all nursing home residents. Hence, in the exam, it is likely that they would have the words nursing home in the question. So this is a case of fecal impaction, and the management here, the most immediate appropriate management would be phosphate enemas. So we have to understand about, first we have to study a little more about fecal impaction. Fecal impaction, the first step is to identify if the stools are hard or soft. For hard stools, we have to consider using a high dose of an oral macrogol or osmotic laxative. For hard stools, we use high dose of oral macrogol or osmotic laxative. For soft stool or for hard stools, after a few days of treatment with macrogol, we have to consider starting or adding an oral stimulant laxative, that is senna or bisacodyl. So for hard stools, we will use high dose of oral macrogol or osmotic laxative. For soft stools or for hard stools after a few days of treatment with oral macrogol, we will use stimulant laxative, oral stimulant laxative, that is senna or bisacodyl. If the response to oral laxatives is insufficient or not fast enough, then we will use a suppository. Bisacodyl is used for soft stools and glycerol is used for hard stools. Glycerol here is a stool softener, or we can use a mini enema like docosate. Docosate is a stool softener as well as a stimulant. If the treatment is still inadequate, then we will prescribe a sodium phosphate. We have to we have to place this sodium phosphate enema. We have to place this high up if the rectum is empty but the colon is full. Phosphate enemas are well known to help with disimpaction quickly, but they should be used as one of the last resorts. Example, if a patient has been admitted for fecal impaction and has tried all the laxatives above but continues to have impaction and discomfort, then one would start phosphate enema. These phosphate enemas can also be used if there is a need for rapid disimpaction. So it can be used in both the cases. As the last resort, when all the other laxatives have been tried and have not worked out, then we can start phosphate enema, or phosphate enemas can also be used if there is a need for rapid disimpaction. Example, the patient is going for a procedure where bowels need to be empty, or if the patient is elderly having obvious abdominal discomfort and is becoming agitated, then we can use phosphate enema. Remember that once successfully disimpacted, it is imperative to start regular oral measures to prevent the recurrence of the problem. So in fecal impaction, first we have to identify whether the stools are hard or soft. For hard stools, we will give high dose of oral macrogol or osmotic laxative. For soft stools, or in case of hard stools where oral macrogol have already been tried, there we will use oral stimulant laxative. Stimulant oral laxative or oral stimulant laxative such as Senna or Bisacodil. If the response to these oral laxatives is insufficient or it is not fast enough, then we can use suppositories or mini enema. So suppository Bisacodil is used for soft stool and glycerol is used for hard stools. Glycerol is a stool softener, and mini enema. Mini enema can be used such as docosate, which is a stool softener and as well as an stimulant, as well as a stimulant. So suppository and mini enema. Now, if the treatment after all this, using oral laxatives and suppositories such as Bisacodil and glycerols, and after using oral laxatives such as oral macrogol and stimulant oral laxatives like Senna, Bisacodil, and using suppositories such as Bisacodil in soft and glycerols in hard, and using mini enema like Docosate. After using all these oral laxatives, even if even then if it's not working out, it's not helping the patient, then we can move further on to using phosphate enemas, sodium phosphate enemas or phosphate enemas. These phosphate enemas have to be placed high up in the rectum if the rectum is empty. These are placed high up if the rectum is empty but the colon is full. So these phosphate enemas are placed high up if the rectum is empty and the colon is full. These phosphate enemas are well known to help with disimpaction of feces, and they help in disimpaction quickly, but they should be used as one of the last resorts. Like we have tried all the laxatives above and the patient continues to have impaction and discomfort, then we can start phosphate enema. They can also be used if there is a need for rapid disimpaction. Phosphate enemas. Let's go through the chart once. So here we are seeing first the thing is the stool hard or soft? If the stool is hard, first we have to soften the stool. So we will give oral macrogol, that is osmotic laxative. Then we can consider adding oral stimulants. If there is no disimpaction after a few days, then we can add oral stimulant laxatives such as Senna or Bisacodil. If the response is poor, Then we can switch to glycerol suppositories. For soft stools, we don't have to soften the stool, we have to directly stimulate the GI tract. As the stool is already soft, so all that is required is the use of oral stimulant laxatives such as senna or bisacodyl. If the response is poor to senna and bisacodyl suppositories, then we can try uh, suppositories like glycerol can be tried here. Now, even then, if the response is poor, then we can try mini enema like docosate at this point, as it is a stool softener as well as a stimulant. But if there is a need for rapid disimpaction, for example, elderly patient having obvious abdominal discomfort, pain plus confusion, agitated, then we can prescribe phosphate enema in that case of, or everything else has been tried, no response, then we can give phosphate enemas. So this is the way how we have to manage a case of fecal impaction. First, hard or soft. Hard, first we have to soften the stool using oral macrogol osmotic laxative. Then we can add further uh, stimulant oral laxatives like bisacodyl or senna if there is disimpaction. If there is no disimpaction after a few days, further, if there is no response or the response is poor, then we can use suppositories like glycerol in hard stool and um, bisacodyl we use in soft stools. If the stools are soft, if the stool is soft, then we don't have to soften the stool as it is already softened. So all that is required is we have to stimulate the GI tract. So we will give stimulant oral laxatives like senna or bisacodyl directly, and then further, if the response is poor, we can use suppositories like bisacodyl. We can use suppositories like bisacodyl in soft stool, and further we can also use mini enemas like docosate, which can be used in both the cases because docosate is both a stool softener as well as a stimulant. So docosate can be used, mini enemas, but if everything has been tried, nothing is working out, no response, then we can give phosphate enemas, and so it can be given for that case as well as for rapid disimpaction. For example, for preparing for a surgery, bowls have to be evacuated or bowls have to be empty, or we have a case of an elderly patient who has been bedridden and having obvious abdominal discomfort, pain, along with that, the patient is agitated and confused, then we can prescribe phosphate enema for rapid disimpaction in that case. So it is important to remember the relation between elderly, bedridden individuals and fecal impaction. Almost 30% of all nursing home residents, we see this thing. So nursing home is a catchword here in this question. These phosphate enemas contain sodium acid phosphate and sodium phosphate. The osmotic activity of sodium acid phosphate increases the water content of the stool, causing rectal distension, which further induces defecation by stimulating the rectal motility. It has a very quick onset of action, which makes enemas very useful where a rapid evacuation of a stony, dull fecal impaction is required. So it is a clear answer for immediate management. The thing is, medications like opioid pain relievers, they reduce intestinal movement and may cause fecal matter to become large, hard, and dry, making it difficult to expel out. Because these opioid pain relievers, they reduce intestinal movement. Subsequently, these feces become so hard that they cannot be expelled, and fecal fluid will flow around the block. Let's move further now. Now we have a 28-year-old man who has been having diarrhea and recurrent abdominal pain several days a month for the last 12 months. The pain improves on defecation. He has mucus in his stools. He describes the pain in the center of his abdomen, the right lower quadrant. He denies any weight loss. His full blood count, celiac, autoantibodies have been found to be normal. On examination, his abdomen is soft but with generalized tenderness. There is no abnormal mass palpable. What is the single most appropriate investigation? And now in this case, fecal calprotectin will be used because it is useful to discriminate between inflammatory bowel disease and irritable bowel syndrome. Irritable bowel disease. It is useful in patients with features of irritable bowel syndrome, like in this case, but they may also have symptoms which overlap with inflammatory bowel disease. So it is unclear if the symptoms are due to inflammatory disease activity or due to irritable bowel disease. Fecal calprotectin is sensitive to gut inflammation. So if the levels of fecal calprotectin are high, if the levels fecal calprotectin is sensitive to gut inflammation. So if the levels of fecal calprotectin are high, then it would indicate inflammatory bowel disease. So abnormal levels would indicate inflammatory bowel disease if the levels are high because it is sensitive to inflammation in the gut. Normal levels would indicate it is an inflammatory irritable bowel disease. Now, the gold standard for diagnosing inflammatory bowel disease is colonoscopy, but it is invasive, costly, and time consuming. It is not appropriate in this case unless the patient has prominent features of inflammatory bowel disease or a fecal calprotectin which is already positive. There are situations in which you would not use a fecal calprotectin, such as new onset of rectal bleeding, bloody diarrhea, patient over 50 years of age with a new change of bowel habits. The reason that one would not use fecal calprotectin in this situation is that a falsely negative test could result in the reassurance of clinician, so we can miss something very important, or a sinister cause can be missed. Fecal calprotectin must be used where cancer is not suspected. So, as we already studied, fecal calprotectin, it is used to discriminate between inflammatory bowel disease and irritable bowel disease, where we have overlapping symptoms and it is unclear. So, this fecal calprotectin is used. It is sensitive to gut inflammation. If the levels of fecal calprotectin are high, it indicates presence of inflammation, that is inflammatory bowel disease. Abnormal levels, the gold standard, whereas the gold standard for inflammatory bowel disease is colonoscopy, but it is an invasive procedure, time consuming, and it is not cost effective. And it is also not appropriate in this case unless the patient is having prominent features of inflammatory bowel disease. Then we can carry out colonoscopy or endoscopy. Or we already have done fecal calprotectin, which was positive. Cases where we will not use fecal calprotectin: newly onset rectal bleeding, bloody diarrhea, patient over 50 years of age with new change of bowel habits. We can have false reassurance here and we can miss something very important or sinister. And fecal calprotectin is also not used where cancer is not. Fecal calprotectin must be used where cancer is not suspected. Okay, let's move further now. Now we have a 32-year-old woman who, who complains of brief episodes of severe shooting pain in the rectum that usually occurs at night. Rectal examination and flexible sigmoidoscopy detect no abnormalities. What is the single most probable diagnosis? So, a 32-year-old woman complains of brief episodes of severe shooting pain in the rectum, which usually occurs at night. Rectal examination and flexible sigmoidoscopy detect no abnormalities. What is the single most probable diagnosis here? So, this is a case of proctalgia fugax. A normal rectal examination and flexible sigmoidoscopy excludes the other options like anal hematoma, anal fissure, piles, rectal carcinoma. They can all be excluded out with the help of rectal examination and flexible sigmoidoscopy. But these are normal in this case. So only proctalgia fugax is left. That's why by ruling out method we come to the conclusion that this is a case of proctalgia fugax. Severe recurrent rectal pain in the absence of any organic disease. Attacks may occur at the night, after bowel actions, or following ejaculation. Anxiety is said to be an associated feature. So a normal so rectal examination and flexible sigmoidoscopy can be used to rule out or to find anal hematoma, anal fissure, rectal carcinoma, or piles. But both these investigations detect no abnormalities here, both are normal. So it is a case of proctalgia fugax. Proctalgia fugax describes a recurrent functional anorectal pain. It is characterized by the presence of sharp pain lasting from seconds to minutes with no interval symptoms between episodes. It is a diagnosis of exclusion once all other possible causes of anorectal pain have been excluded, such as hemorrhoids, abscesses, fissures, etc. In this, we will see severe recurrent rectal pain in the absence of any organic disease, proctalgia fugax. Attacks may occur at night, after bowel actions, or after ejaculation. Anxiety is said to be an associated feature in proctalgia fugax. There is a recurrent functional anorectal pain characterized by presence of sharp pain lasting from seconds to minutes with no interval, symptoms between episodes, diagnosis of exclusion, and once all other possible causes of anorectal pain have been excluded, like anal hematoma, anal fissure, hemorrhoids, abscesses, fissures, rectal carcinoma, anal fissure, hematoma, piles, etc. So that was proctalgia fugax. Let's move further. Now we have a 45-year-old smoker has suspected esophageal carcinoma with a mass seen within the middle third of the esophagus with metastasis to the liver. He has severe dysphagia, which has worsened over the past few months since his diagnosis. What is the single most appropriate management to treat his symptoms? Now we see here dysphagia from inoperable esophageal cancer, which is a complex issue, and it has a little consensus on the ideal management approach. So, for advanced cases of esophageal cancer that are causing dysphagia, insertion of a stent into the esophagus may be recommended. And this esophageal cancer is inoperable here. The stent expands once in place and holds the esophagus open to manage symptoms of dysphagia. Although radiotherapy also provides symptom relief, long-term relief, the waiting time for initiation for radiotherapy is long, and there are long lag times between initiation of treatment and relief of symptoms. So there are long lag times between initiation of treatment and relief of symptoms as well. Endoluminal stents provide more rapid and effective early relief for symptomatic patients. Now, percutaneous endoscopic gastrostomy. Percutaneous endoscopic gastrostomy is an endoscopic medical procedure in which a tube is passed into a patient's stomach through the abdominal wall to provide a means of feeding when oral intake is not adequate. This is usually done in stroke patients who are at a risk of aspiration pneumonia or to decompress the stomach in case of gastric volvulus. So let's study a little more about oral esophageal stents. An esophageal stent is a tube placed in the esophagus to keep a blocked area open so that the patient can swallow soft food and liquids. Esophageal stents may be self-expandable metallic stents or made of plastic or silicone. These are used primarily in palliative cancer treatment. So, dysphagia from an inoperable esophageal cancer is a complex issue with little consensus on the ideal management approach. For advanced case of esophageal cancer causing dysphagia, insertion of a stent, esophageal stent, is recommended, and this stent can expand once in place and can hold the esophagus to manage the symptoms of dysphagia. Radiotherapy can provide long-term symptomatic relief, but the waiting time for initiation of radiotherapy is long, as well as there is a long lag time between initiation of therapy and relief of symptoms. So endoluminal stents are a better alternative because they provide more rapid and effective early relief for symptomatic patients. Percutaneous endoscopic gastrostomy is an endoscopic medical procedure in which a tube is passed into a patient's stomach through the abdominal wall to provide a means of feeding when oral intake is not adequate and we cannot approach orally. This is usually done in stroke patients who have a high risk of aspiration pneumonia who are at the risk of aspiration pneumonia, or to decompress the stomach in case of gastric volvulus. Okay, let's move further. Now we have a 20-year-old woman with a history of type 1 diabetes presenting to her GP complaining of a 6-week history of intermittent abdominal pain with mild diarrhea. She also reports fatigue and 8 kg of weight loss over past 6 months. She denies any blood in her stool. Examination reveals conjunctival pallor, aphthous ulcers. Which investigation should be considered first? So now we are seeing a case with history of type 1 diabetes and 6-week history of intermittent abdominal pain with mild diarrhea. There is weight loss of 8 kg over past 6 months, fatigue, no blood in stools, but there is conjunctival pallor and aphthous ulcers. So next investigation which should be considered, or the first investigation which should be considered here. So the answer here is serum tissue transglutaminase. The patient is presenting with signs of malabsorption, such as the patient is having weight loss, having conjunctival pallor, and having aphthous ulcers. So both celiac disease as well as inflammatory bowel disease are potential differentials here. Can be celiac disease, can be inflammatory bowel disease. In both the cases, malabsorption is there. Patient is having weight loss as well as conjunctival pallor is there, aphthous ulcer. Celiac disease is more likely as it is more commonly associated with type 1 diabetes. That is a thing to remember here. Celiac disease is more likely because it is more commonly associated with type 1 diabetes mellitus as compared to inflammatory bowel disease. So a blood test to investigate celiac disease should therefore be the first investigation to consider. 5% of patients with type 1 diabetes mellitus have celiac disease. According to NICE guidelines, celiac disease should be screened for at diagnosis of type 1 diabetes mellitus and then screened for yearly due to the intrinsic link between these two autoimmune diseases. So even at the diagnosis of type 1 diabetes mellitus, celiac disease should be screened. And after that, it should be screened annually or yearly because there is an intrinsic link between these two autoimmune conditions because both are autoimmune, type 1 diabetes mellitus as well as celiac disease. Diagnosis of celiac disease is made by small intestinal biopsy. Diagnosis of celiac disease is made by small intestinal biopsy histology, which would show the presence of villus atrophy, crypt hyperplasia. A biopsy is taken by an endoscopy, and this is an invasive test, which should not be the first line investigation for a suspected case of celiac disease. A blood test or for autoantibodies like tissue transglutaminase antibody, serum tissue transglutaminase IgA antibody, or anti-endomysial antibodies IgA. Those are the first line investigations. A blood test for serum tissue transglutaminase IgA antibody is non-invasive, specific and sensitive test for celiac disease. If this is positive, then patient can undergo an endoscopy and biopsy for confirming the diagnosis. So we should directly remember that type 1 diabetes mellitus is associated with celiac disease. Celiac disease we know caused due to it's an autoimmune condition where the patient is sensitive to gluten in the diet. So that type 1 diabetes mellitus, which is autoimmune, is linked with celiac disease intrinsically. So again, here the patient is having signs of malabsorption such as weight loss, conjunctival pallor, and aphthous ulcers. Now, it can be due this malabsorption can be due to celiac disease or inflammatory bowel disease, but celiac disease is more likely because the patient is having history of type 1 diabetes mellitus, and celiac disease is more commonly associated with type 1 diabetes mellitus. Therefore, a blood test should be carried out to rule out or to investigate celiac disease. So, NICE guidelines recommend that at the diagnosis of type 1 diabetes mellitus, celiac disease should be screened at the time of diagnosis, and then celiac disease should be screened yearly due to an intrinsic link between these two autoimmune diseases. 5% of the patients with type 1 diabetes mellitus have celiac disease. Now, first we can carry out investigations like tissue transglutaminase IgA antibodies or anti-endomysial antibodies IgA. Then we can carry out endoscopy and biopsy histology to confirm the diagnosis, where we will see villus atrophy, crypt hyperplasia, and all such features. But as it is an invasive test, endoscopy, it is not done as a first line investigation. First, we'll do antibodies test. Let's move further. Now we have a 52-year-old man who underwent a partial gastrectomy 10 years ago, presenting with increased fatigue. He also shows signs of cognitive deterioration, peripheral paresthesia, and disturbances of position and vibration sense. A yellow tinge is noted on his skin. He has a red sore tongue. A recent full blood count shows macrocytic anemia. What is the single most likely diagnosis here? So we are seeing yellow tinge, that is patient is showing jaundice, features of jaundice, folate deficiency, B12 deficiency. So this is a case of B12 deficiency. Findings on examination for B12 deficiency may include lemon tinge to the skin. Okay, so that yellowish tinge is not necessarily denoting jaundice, but this B12 deficiency may include lemon tinge to the skin as well and glossitis. The neurological findings and hematological findings, together with a history of gastric resection whereby malabsorption of B12 could occur, point towards the diagnosis of B12 deficiency. So talking about B12 deficiency. Let's study about it a little more. So, vitamin B12 is found in meat, fish, and dairy products, but not in plants. Vitamin B12 then binds to an intrinsic factor in the stomach, and this complex is then absorbed in the terminal ileum. It binds to Casel's intrinsic factor in the stomach, and this complex is then absorbed in the terminal ileum. Clinical presentation of B12 deficiency is symptoms are those of chronic anemia, such as there would be fatigue, difficulty in breathing, dyspnea on exertion. Neurological symptoms may also be present, such as classically peripheral paresthesia, disturbance of position and vibration sense. If it is uncorrected, the patient may develop subacute combined degeneration of spinal cord leading to permanent ataxia. Causes of B12 deficiency: it can be pernicious anemia, which is the commonest cause of B12 deficiency, pernicious anemia. It is due to autoimmune gastric atrophy resulting in loss of Casel's intrinsic factor, which is required for absorption of B12. Usually, this pernicious anemia is associated with other autoimmune conditions such as hypothyroidism. So, causes of B12 deficiency: first, pernicious anemia, which is the commonest cause. Due to autoimmune gastric atrophy, there is loss of Casel's intrinsic factor required for absorption of B12, and it is usually associated with other autoimmune conditions such as hypothyroidism. Second, dietary cause can be if the source of if the food source is not involving any meat, fish, or dairy products. So, in case of vegans, we can have so dietary causes can be there. Example: vegans or following total gastrectomy. Following total gastrectomy, because body stores can last for a few years, gastrectomy would only cause depletion of the stores of vitamin B12 or depletion of cobalamin stores after 1 to 2 years of surgery. Ileal disease, as we understood that vitamin B12 is absorbed in the terminal ileum. So if there is ileal disease such as resection of ileum or Crohn's disease, then also we will see vitamin B12 deficiency. Or there are malabsorption disorders like celiac disease or tropical sprue. So malabsorption disorders like celiac disease and tropical sprue can also cause vitamin B12 deficiency. Now, coming to hematological abnormalities of B12 deficiency. First, macrocytic anemia, MCV more than 110, seen in both folate and B12 deficiency. Second, hypersegmented neutrophils, seen in both folate and B12 deficiency. Third, serum B12 is low. Fourth, homocysteine. Homocysteine is a supplementary test where there is an indeterminate serum B12 level. Deficiency of cobalamin results in elevation of plasma total homocysteine. This is not specific to cobalamin deficiency because concentration of plasma total homocysteine is also elevated in folate deficiency. Management: hydroxycobalamin intramuscularly. So we understood that the source of vitamin B12 is meat, fish, and dairy. It is not found in plants. And we understood that it binds to intrinsic factor, Casel's intrinsic factor in the stomach, and then is absorbed in the terminal part of ileum. Clinical presentation is just like chronic anemia. The patient shows fatigue and dyspnea on exertion. Neurological symptoms may also be present, such as classical peripheral paresthesia, and also there may be disturbance of vibration sense and position sense. If it is uncorrected, then the patient may also develop subacute combined degeneration of spinal cord leading to permanent ataxia. Permanent ataxia can also occur. Causes of B12 deficiency are first pernicious anemia, which is the commonest cause due to gastric atrophy, autoimmune gastric atrophy. There is loss of Casel's intrinsic factor, so leading to malabsorption or non-absorption of vitamin B12. And it is this pernicious anemia is usually associated with other autoimmune conditions such as hypothyroidism. Now, second thing is dietary causes. Dietary causes can be like a vegan diet. So dietary cause is there. Third is following total gastrectomy. Following total gastrectomy, because body stores can last only for a few years, so gastrectomy would cause depletion of all the cobalamin stores after 1 to 2 years of surgery. Then fourth one is ileal disease, ileal resection or Crohn's disease. And fifth one is malabsorption disorders like celiac disease or tropical sprue. These are the causes. Hematological abnormalities are macrocytic anemia, MCV more than 110, hypersegmented neutrophils, high homocysteine levels, high plasma or high serum total homocysteine levels, and serum B12 is low. All these features, macrocytic anemia, hypersegmented neutrophils, and high homocysteine levels, these are found in both folate and B12 deficiency. Management is by giving hydroxycobalamin intramuscularly. So, what is the most common cause of vitamin B12 deficiency in the United Kingdom? It is pernicious anemia. In pernicious anemia, there is lack of Casel's intrinsic factor secretion in the stomach due to gastric atrophy, which is resulting in poor absorption of vitamin B12 in the ileum. Other causes are veganism, that is, vegan diet, total gastrectomy, again, lack of intrinsic factor, ileal resection, Crohn's disease, chronic pancreatitis, or celiac disease. So, malabsorption includes celiac and tropical sprue. New cause here is chronic pancreatitis. So, veganism, total gastrectomy, ileal resection, Crohn's disease, and celiac disease, tropical sprue, chronic pancreatitis, pernicious anemia, most common cause, then diet. Okay, so this is a chart here of vitamin B12 deficiency. So now we have to study about the comparison of the causes between vitamin B12 and folate deficiency. Vitamin B12 deficiency and folate deficiency. Basically, vitamin B12 deficiency in this, there, if the cause is malabsorption, then it is caused due to pernicious anemia. Whereas in folate deficiency, there is poor bioavailability. Medical conditions, inflammation of small intestine such as celiac disease, tropical sprue, Crohn's disease, gastric resection can also cause for the reason of obesity or cancer. But gastric resection would not cause folate deficiency. But their medical conditions or inflammation of small intestine like celiac disease, tropical sprue, Crohn's disease can cause folate deficiency. Inadequate dietary intake, low intake of cobalamin rich foods, and folate deficiency, low intake of folate rich foods. So, a useful tool to remember which foods have which vitamins is fruits and vegetables contain folate. Beef and bacon contain B12. So, folate usually comes from fruits and vegetables. Fruits and vegetables, whereas B12 is coming from beef and bacon. Good food sources of folate include broccoli, Brussels sprouts, asparagus, peas, basically vegetables and fruits. Broccoli, asparagus, peas, and Brussels sprouts. So, if the given scenario is a vegan, it is unlikely that he is suffering from folate deficiency. In that case, we have to pick B12 deficiency. Folate comes from fruits and vegetables, and B12 B comes from beef and bacon. Gastric resection can cause B12 deficiency, but gastric resection would not cause folate deficiency. That is the main difference here. So now let's move further. Now we have a 35-year-old man presenting with burning retrosternal pain for the past few days. He has recently completed a course of treatment for H. pylori, and endoscopy shows multiple ulcers along the lower esophagus, stomach, and duodenum. What is the single most appropriate investigation here? So now we have to study about a syndrome called Zollinger-Ellison syndrome. Now, Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is characterized by gastric acid oversecretion due to excessive levels of gastrin secreted from tumors found in the duodenum or pancreas. It presents as a severe peptic ulcer disease, gastroesophageal reflux, and diarrhea. Now, when to suspect this Zollinger-Ellison syndrome? We have to suspect in those who are having multiple peptic ulcers resistant to drugs. Second, if associated with diarrhea or steatorrhea. Third, associated with a family history of peptic ulcers. Now we have to understand here that it is associated with oversecretion of gastric acid due to excessive levels of gastrin which is secreted from duodenum and pancreas. Let's go through the chart. So Zollinger-Ellison syndrome, gastrinoma causes leading to excess gastrin levels, leading to multiple and refractory peptic ulcers in the distal duodenum and proximal jejunum. Presentation is epigastric pain, GI bleeding due to erosion, chronic diarrhea associated with MEN 1 syndrome. Associated with MEN 1. Investigations are fasting serum gastrin level, endoscopy to look for ulcers, and CT scan to locate the tumor in duodenum or pancreas. That is leading to excess secretion of gastrin, which is leading to over secretion of gastric acid. Treatment is surgical resection of the tumor and proton pump inhibitors. So this is about Zollinger-Ellison syndrome. As we studied, Zollinger-Ellison syndrome is characterized by gastric acid oversecretion due to excessive levels of gastrin secreted from the tumors found in duodenum and pancreas. This Zollinger-Ellison syndrome presents as a severe peptic ulcer disease, gastroesophageal reflux, and diarrhea. We have to suspect Zollinger-Ellison syndrome in those who are having multiple peptic ulcers resistant to drugs or associated with diarrhea or staturia or associated with family history of peptic ulcers. So Zollinger-Ellison syndrome, there is tumor uh, or gastrinoma leading to excess gastrin, leading to multiple and excessive secretion of gastric acid, leading to multiple and refractory peptic ulcers in the distal duodenum and proximal jejunum. Presentation is, as we studied, it is like peptic ulcer disease, gastroesophageal reflux, and diarrhea. So there is epigastric pain. There is GI bleed due to erosion due to multiple peptic ulcers. GI bleeding can be there due to erosion. There is chronic diarrhea, and it is associated with MEN1. Zollinger-Ellison syndrome is associated with MEN1. This is a thing to remember. Investigation. Here we have to carry out serum gastrin levels, endoscopy to look for ulcers, and CT scans so as to locate the tumor. So endoscopy to look for ulcers, serum gastrin levels, fasting serum gastrin levels, and CT scan to look for the tumor. Treatment is surgical resection of the tumor or gastrinoma and proton pump inhibitors. So the gastrin levels needs to be checked to rule out a gastrinoma. A gastrinoma is a neuroendocrine tumor usually found in the pancreas or duodenum. These tumors secrete gastrin, which stimulates the parietal cells of the stomach to secrete hydrochloric acid into the stomach cavity, leading to intractable peptic ulcerations. Gastrinomas are suspected when peptic ulcers occur at unusual sites, such as the second part of the duodenum or jejunum, or ulcers recurring after adequate surgery. One third of the patients having One third of the patients have watery diarrhea due to high gastric output. Diagnosis is made by measurement of fasting gastrin levels or secretin stimulation test. So these are found, this Zollinger-Ellison syndrome is found in cases of gastrinoma. This gastrinoma is a neuroendocrine tumor usually found in duodenum or pancreas. It leads to excessive secretion of gastrin, which further leads to excessive secretion of gastric acid, leading to multiple refractory peptic ulcers at unusual sites of like distal duodenum and proximal ileum, proximal jejunum, and leading to symptoms such as epigastric pain, GI bleed due to erosion, There can be diarrhea due to increased gastric output, chronic diarrhea, and it is Zollinger-Ellison syndrome is situated with men 1. And investigations we can perform fasting serum gastrin levels, then endoscopy to look for ulcers, and CT scan to look for the tumor, treatment resection of tumor, and proton pump inhibitors. So this is about Zollinger-Ellison syndrome, men 1. Let's move further. Now we'll take a small break here and I'll be back. So now we have a 52-year-old smoker complaining of troubled swallowing and burning pain under the sternum, which is worse after a large meal. He has a history of hiatus hernia seen 12 years ago. He takes regular lansoprazole, and when the pain is worse, he has to take antacids. He was sent for an endoscopy, which reveals inflammatory changes in the lower esophagus. What is the single most likely diagnosis? So, this is a case of Barrett's esophagus. Long standing heartburn and dysphagia are typical symptoms of gastroesophageal reflux disease. Smoking is a risk factor for gastroesophageal reflux disease, and hiatus hernia will further exacerbate this condition. The inflammatory change occurring in the lower esophagus as the gastric acid is refluxed up and causes damage to the cells of the lower esophagus. The chronic reflux would result in the replacement of the squamous epithelium to the columnar epithelium, which is seen in Barrett's esophagus. Barrett's esophagus is a pre-malignant condition with a 10% lifetime risk of developing esophageal adenocarcinoma. Therefore, the patient needs to be monitored closely going forward. Let's study a little more about Barrett's esophagus. So, Barrett's esophagus results from prolonged exposure of normal esophageal squamous epithelium to the acid reflux seen in gastroesophageal reflux disease. This mucosal inflammation and erosion occurs. It leads to mucosal inflammation and erosion, which leads to replacement of the mucosa with metaplastic columnar epithelium. So we have to think of Barrett's esophagus and cervical ectropion the same way because the columnar cells are replacing the squamous cells. The columns are coming is the tip here. There is an increased risk of esophageal adenocarcinoma in patients with Barrett's esophagus. Therefore, these patients need to be monitored closely. So, the patient is having symptoms like long-standing heartburn and dysphagia, which are typical of gastroesophageal reflux disease. And smoking is also a risk factor. Hiatus hernia will further exacerbate this condition. The inflammatory change occurring in the lower esophagus as a gastric the inflammatory change occurs in the lower esophagus as the gastric acid is refluxed up and it causes damage to the cells of the lower esophagus. What occurs here? Inflammation occurs as well as mucosal inflammation occurs as well as erosion occurs, which further leads to replacement of this squamous epithelium by metaplastic columnar epithelium due to prolonged exposure to the acid reflux seen in gastroesophageal reflux disease. This esophagus is called as Barrett's esophagus, which is lined by metaplastic columnar epithelium. It is a pre-malignant condition with 10% risk of developing esophageal adenocarcinoma. Therefore, the patient needs to be monitored closely. Columns are coming. So this is about Barrett's esophagus. Let's move further. Now we have a 42-year-old obese woman who has severe upper abdominal pain. She vomited several times today. She has a temperature of 37.8 degrees Celsius. She is married, having 5 children who are living. She has no previous surgeries, and her blood count hemoglobin is 123, white cell count is 17.3, platelet count 150, CRP is 180. So the single most likely diagnosis is being asked here. Now we have to remember the mnemonic for gallstones. We have to remember the 5F, which are female, fertile, fair, fat, 40. Female, fertile, fair, fat, 40. So these are the risk factors. She has a number of these risk factors. Of course, the patients with acute cholecystitis would usually have a gallstone history and gallstones seen on scans previously. So this is a case of cholecystitis. This patient might be having gallstones which have further led to cholecystitis in this patient. We have to remember the mnemonic for gallstones, that is 5F. What was the 5F? Female, fertile, fatty, 40, and fair. Female, fertile, fatty, 40, and fair. These are the 5Fs. And she has these risk factors. So patient with acute cholecystitis would usually have a gallstone history. So this is a case of cholecystitis. Now let's move further here. We have to see in history things like gallstones and alcohol intake, such things. Okay, so now we have a 56-year-old man coming for a routine checkup. He is noted to have increased skin pigmentation, spider angioma, and a heart murmur. He has mild joint pain, particularly in those of the hands. He rarely drinks alcohol. On examination, his liver is firm and has a span of 10 centimeters. On further investigations of the heart murmur, he was given the diagnosis of restrictive cardiomyopathy. What is the single condition that he is most likely at risk of? So now we have to study about hemochromatosis, and we have to know what is hepatoma here. So hepatoma or hepatocellular carcinoma is a primary malignancy of the liver. The given scenario here has features of hemochromatosis, of which is among the causes of restrictive cardiomyopathy. It is a very well known fact that patients with hemochromatosis have an increased risk of developing hepatocellular carcinoma. The liver is a primary storage area for iron and will naturally accumulate excess iron. Over the time, the liver is likely to be damaged by iron overload, leading to cirrhosis. Cirrhosis and hemochromatosis together will increase the risk of hepatocellular carcinoma. Now, hereditary hemochromatosis is an autosomal recessive genetic disease in which hereditary hemochromatosis is an autosomal recessive genetic disease in which there is increased intestinal absorption of iron causing accumulation in the tissues, especially the liver, which may lead to organ damage. Other organs affected are pancreas, joints, heart, skin, and gonads. Presentation: early diagnosis is difficult because the patient is often asymptomatic until the later stages. Symptoms usually start between ages 40 to 60. Initial symptoms are vague, non-specific, like fatigue, weakness, heart problems. Hemochromatosis may be diagnosed incidentally following abnormal serum ferritin or liver function tests. Symptoms of advanced disease include diabetes, bronzing of the skin, hepatomegaly, cirrhosis, arthropathy, cardiac diseases such as arrhythmia or cardiomyopathy, neurological or psychiatric symptoms like impaired memory, mood swings, irritability, and depression. We have to remember the triad in hemochromatosis, the triad of diabetes, hepatomegaly, and bronze pigmentation. Diabetes, hepatomegaly, and bronze pigmentation, this triad is seen in 30% of the patients with hemochromatosis and is a common presentation given in the questions. If both the parents are carriers, what are the chances of the child having the disease? It is 25% because it is autosomal recessive. So again, hereditary hemochromatosis is an autosomal recessive genetic disease in which increased intestinal absorption of iron causes accumulation of iron in the tissues, especially liver, which is the main storage area of iron. So it may lead to organ damage, it may lead to cirrhosis because it is the main area, primary area for storage of iron. So in case of iron overload, it will lead to organ damage or liver damage, cirrhosis. Other areas affected, other organs affected by iron deposits are pancreas, joints, heart, gonads, skin, etc. Presentation of hemochromatosis: early diagnosis is difficult. Patient is often asymptomatic until the later stages. Symptoms usually starting 40 to 60 age. Initial symptoms are vague, non-specific, like fatigue, weakness, heart problems. It may be diagnosed incidentally, like abnormally high levels of serum ferritin or deranged LFT. Then symptoms of advanced disease include diabetes, bronzing of the skin, hepatomegaly, cirrhosis, arthropathy, diabetes, bronzing of the skin, hepatomegaly, cirrhosis, Arthropathy, cardiac diseases like arrhythmias and cardiomyopathy, neurological symptoms or psychiatric symptoms like irritability, mood swings, depression, impaired memory, etc. We have to remember a triad in hemochromatosis. This triad is triad of diabetes, bronzing of the skin, and hepatomegaly. Diabetes, bronzing of the skin, and hepatomegaly. This is a triad of hemochromatosis seen in 30% of the patients. Common presentation. Autosomal recessive. Okay, so hepatoma or hepatocellular carcinoma is a primary malignancy of liver. The given scenario has features of hemochromatosis, of which is among the causes of restrictive cardiomyopathy. Now, it is a very well known fact that patients with hemochromatosis have an increased risk of developing hepatocellular carcinoma. Liver is a primary storage area of iron, will naturally accumulate excess iron. So over the time, it's likely to be damaged by iron overload, leading to cirrhosis. Cirrhosis and hemochromatosis together will increase the risk of hepatocellular carcinoma. Now let's move ahead. Here we have now a 61-year-old woman complaining of intermittent chest pain and dysphagia. His symptoms have been Her symptoms have been gradually worsening over the past 12 months, and also suffering with heartburn and takes regular omeprazole. Patient had an esophagogastroduodenoscopy 6 months ago, which showed evidence of a tortuous esophagus. A recent barium swallow shows the following images. Now, what is the single most likely diagnosis? Now, here we can see a corkscrew pattern which can be observed on barium swallow, which is an indicative of diffuse esophageal spasm. Corkscrew appearance, we have to remember 4 C's in diffuse esophageal spasm. Corkscrew appearance on barium swallow, contractions on manometry, and cold drinks can precipitate, and calcium channel blockers and nitrates. In the chart, we'll come back. First, let's go through quickly through the chart of hemochromatosis. It's an autosomal recessive disorder causing increased absorption of iron, resulting in iron overload. Presentation: arthropathy, bronze skin, hepatomegaly leading to cirrhosis, leading to hepatocellular carcinoma, cardiac abnormalities like cardiomyopathy, arrhythmias, neurological impaired memory, depression, endocrine, diabetes, impotence, amenorrhea, triad of diabetes, bronzing of skin, and hepatomegaly. There can be cirrhosis, hepatocellular carcinoma, then cardiac conditions, cardiomyopathy and arrhythmia, neurological conditions, and psychiatric conditions. Investigations: serum ferritin levels, and transferrin saturation, and genetic testing. Treatment is liver transplantation because of cirrhosis, and phlebotomy and liver transplantation in cirrhosis. Now let's see. Now, this is diffuse esophageal spasm. So, diffuse esophageal spasm is uncoordinated esophageal contractions. Presentation is intermittent and unpredictable chest pain, second dysphagia. Investigation most initial is endoscopy, anyone with dysphagia, second esophageal manometry, which is a gold standard method, third barium swallow, in which we will see corkscrew pattern in diffuse esophageal spasm. Treatment is by nitrates, calcium channel blockers like nifedipine, and botulinum toxin injection. So a corkscrew pattern can be observed in barium swallow, on barium swallow in case of diffuse esophageal spasm, which is an indicator of that. Gold standard test in diffuse esophageal spasm is esophageal manometry, but this has not been performed yet, or perhaps because it is an area where it is not available in this question. So, as we studied about diffuse esophageal spasm, diffuse esophageal spasm, also known as distal esophageal spasms, these are the contractions which are disorganized, so they do not lead to the forward flow of food. So these contractions are disorganized, so they do not lead to the forward flow of food, that is peristalsis. So we are looking at uncoordinated esophageal contractions. So we are looking at uncoordinated esophageal contractions, or contractions are not organized, disorganized, so they do not lead to peristalsis or forward flow of food. Clinical presentation, there is intermittent chest pain, dysphagia. Pain can be so severe that it simulates that of myocardial infarction, MI. Pain can be precipitated by drinking cold liquids. Now, diagnosis. The most initial diagnosis investigation is endoscopy. Endoscopy will not diagnose diffuse esophageal spasm, but it is needed for anyone with dysphagia to rule out cancer first. In medical school, many of you may have been taught that barium swallow would be the first investigation to perform prior to endoscopy, as it is less invasive. But over the past few years, it has changed. And now endoscopies are performed first to rule out cancer for anyone with dysphagia. This goes in line with NICE guidelines. But the gold standard for diffuse esophageal spasm is esophageal manometry. The most accurate test is manometric studies, which will show high intensity disorganized contractions. Barium studies show corkscrew pattern at the time of spasm, but it is only done in rare situations currently, such as if esophageal manometry is not available. Treatment is by calcium channel blockers like nifedipine and nitrates. So, diffuse esophageal spasm, it is consisting of uncoordinated esophageal contractions. Presentation is intermittent and unpredictable chest pain and dysphagia. Investigation most initial is endoscopy, and even with dysphagia, esophageal manometry, which is gold standard, and barium swallow, in which we will see corkscrew pattern in diffuse esophageal spasm. Treatment is by nitrates, calcium channel blockers like nifedipine, nitrates, and botulinum toxin. The contractions here are disorganized, so they do not lead to peristalsis or forward flow of food. Clinical presentation will include intermittent chest pain and dysphagia. Pain can be severe, sometimes just like MI. Pain can be precipitated by drinking cold liquids. Diagnosis, most initial investigation is endoscopy. Gold standard is esophageal manometry. Barium swallow can also be performed, in which we will see corkscrew pattern or corkscrew appearance. Esophageal manometry, which is the gold standard, is the most accurate test, which will show high intensity disorganized contractions. Treatment, calcium channel blockers like nifedipine and nitrates. Now let's move further. So now we have here a 25-year-old man presenting to his GP with the complaint of diarrhea for the last 7 days. Upon further questioning, he reveals that he opens his bowels in excess of 2 to 6 times per day. He describes his stool as being watery in consistency. He has also noticed blood in his stool. When asked about the character of the blood, the patient claims that the blood appears to be fresh, was bright red in color. He also complains about abdominal pain, describes his pain as being cramping in nature. He complains about an urgency to visit the toilet all the time. The patient is a bank manager by profession. For the last 7 days, he has been unable to cope with the situation. He says that it is affecting his work, overall general health, as he is feeling very tired, lethargic all the time. He complains about the lack of appetite. He has not traveled outside of the United Kingdom for the last 8 months. The patient has no significant past medical history, does not have any allergies. On examination, the blood pressure is 120/80, heart rate is 70, abdomen is tender with no guarding or rigidity. What is the single most appropriate investigation which we will perform to aid in the management of this patient? So here we have to study about certain protocols and classification of diarrhea by WHO. Now, the World Health Organization classification of diarrhea is diarrhea if more than 3 loose or watery stools per day, acute diarrhea less than 14 days, chronic diarrhea more than 14 days. According to this classification, it is too early to decide in this patient if he is suffering from ulcerative colitis or not, because he has had diarrhea only for the last 7 days. Now, at this stage, it is best to exclude the infectious causes first by doing a stool microscopy culture and sensitivity test. In such cases, the investigations largely depend on the clinical setting. For example, in primary care, the main aim is to make the diagnosis. In secondary care, to confirm the diagnosis as well as to assess the severity and the extent of the disease. In primary care, the test must include a stool culture and sensitivity to exclude the infectious causes of diarrhea such as Salmonella, Shigella, E. coli, Clostridium difficile, Campylobacter, and Giardiasis. Once the infectious causes are excluded, further diagnostic tests like colonoscopy with biopsy can be done in secondary care. Fecal fat test is not the correct option because it is primarily ordered when a patient has signs and symptoms of malabsorption such as steatorrhea, persistent diarrhea, abdominal pain, bloating, weight loss, failure to thrive in children. Fecal antigen test is a stool test used to detect Helicobacter pylori. It is an irrelevant test to perform in this patient. So, because here the patient is complaining of diarrhea for the last 7 days, so we are not in a position to classify. It is too early to decide if the patient is suffering from ulcerative colitis or not. According to WHO, diarrhea can be classified as it is diarrhea if there are more than 3 loose or watery stools per day. Acute diarrhea less than 14 days, chronic diarrhea more than 14 days. So at this stage, it is best to exclude the infectious causes. So we should do a stool microscopy culture and sensitivity test so as to exclude out all the infectious causes. Obviously, investigation depend on the clinical setting. In primary care, the main aim is to make the diagnosis. In secondary care, the main aim is not just to make the diagnosis, it is to confirm the diagnosis as well as to find out the severity and extent of the disease. In primary care, the test must include a stool culture, microscopy, and sensitivity to exclude the infectious causes of diarrhea such as Shigella, Salmonella, E. coli, Clostridium difficile, Campylobacter, Giardiasis. Once these infectious causes are excluded, then we can further carry out diagnostic tests like colonoscopy with biopsy can be done in secondary care. Fecal fat test is not a correct option here because we will have symptoms of malabsorption then. So, steatorrhea, persistent diarrhea, weight loss, bloating, abdominal pain, failure to thrive, those would be present. Antigen test, fecal antigen test is also, which is used to detect H. pylori, is also irrelevant here. So now let's move further. Here we have a 70-year-old man presenting with persistent dysphagia to both solids liquids for a few months. No associated weight loss, does not have regurgitation after meals, suffers from dyspepsia, occasionally have a burning sensation of his chest which lasts for a few hours before it fades away. His medical history includes osteoporosis, for which he takes alendronate once a week for the past 2 years. So we have to find out the single most likely diagnosis here. So this is a case of benign esophageal stricture. Patient with GERD progress to have dysphagia, and this can be due to three things: Barrett's esophagus plus, that is long standing GERD, plus intermittent or occasional dysphagia, or benign esophageal stricture in which there is persistent dysphagia, usually more to solids than liquids. Then carcinoma of esophagus, progressive dysphagia in older age groups. So in GERD, there can be Barrett's esophagus leading to intermittent dysphagia, or there can be benign esophageal stricture having persistent dysphagia, or there can be carcinoma of esophagus in which there is progressive dysphagia. So GERD, Barrett's esophagus, benign esophageal stricture, and esophageal carcinoma. Barrett's esophagus, intermittent dysphagia, benign esophageal stricture, persistent dysphagia, and esophageal carcinoma, progressive dysphagia. Now, benign esophageal strictures usually benign esophageal strictures usually occurs as a result of scarring from acid reflux in severe and persistent GERD. It may also follow ingestion of corrosives. While the area heals, a scar forms. It causes the tissue to pull and tighten, leading to difficulty in swallowing. Certain drugs like alendronate, NSAIDs, have the potential to cause strictures due to their side effects which worsen GERD. This is seen in this question where the patient is taking alendronate. This is the reason that it is important to advise patients not to lie down for at least 30 minutes after taking alendronate, as this will help alendronate reach the stomach faster and prevent irritation of the esophagus. Now, esophageal carcinoma, the absence of any significant weight loss makes esophageal carcinoma a less likely diagnosis here. But it is important to note that any cause of dysphagia can essentially cause weight loss. This includes both benign esophageal structure as well as achalasia. Barrett's esophagus would also have a long history of GERD, which is seen. However, the symptoms of dysphagia is usually occasional rather than persistent. So in Barrett's, we will have occasional or intermittent dysphagia, not persistent. In pharyngeal pouch, usually presents with history of halitosis, regurgitation of undigested food, and a sensation of lump in the throat, neck bulge. Achalasia. While the most common feature is dysphagia, regurgitation is a very common feature of achalasia, occurs in around 80 to 90% of sufferers. But this patient does not have regurgitation. So if the patient does not have the history of taking alendronate, the answer is still likely to be benign esophageal stricture, given that there is less evidence for any other option. So we have to remember with GERD, there can be three possibilities: Barrett's esophagus, benign esophageal stricture, and esophageal carcinoma. Barrett's esophagus, we will have intermittent or occasional dysphagia. In benign esophageal stricture, we will have persistent dysphagia. In esophageal carcinoma, we will have progressive dysphagia. Now, benign esophageal stricture, these are occurring as a result of scarring from acid reflux in severe and persistent GERD. It may also occur following ingestion of corrosive agents. While this area heals, scar is formed, causing the tissue to pull and tighten, leading to difficulty in swallowing. Certain drugs also, like alendronate and NSAIDs, they also have the potential to cause strictures due to their side effects, further worsening GERD, which is the case here. This is the reason it is important to advise these patients not to lie down for at least 30 minutes after taking alendronate, so that it can reach stomach faster and preventing irritation of the esophagus. In pharyngeal pouch, we will see history of halitosis and regurgitation of undigested food and a sensation of lump in the throat or neck bulge. In achalasia, we will see regurgitation, which is a very common feature of achalasia, but here it is absent. Although dysphagia is the most common feature there as well, but regurgitation has to be there. So now let's take a break for a while and I'll be back.